I was not even aware of MR-Linac. Now suddenly we have trials that are testing radiotherapy with immunotherapy in rectal cancer. I think this is the next big thing that is coming in rectal cancer treatment.
Professor Cihan Gani is Deputy Chair of Radiation Oncology at the University Hospital Tübingen, where he has been at the forefront of MR-guided radiotherapy, leading transformative research into organ-preserving treatments for rectal cancer. In this episode, we'll explore the MRs trial, an ambitious international study investigating MR adaptive dose escalation to boost clinical complete response rates in rectal cancer patients. With early results in the pre-trials showing promising remission rates and improved quality of life, Professor Gani's work is offering new hope to patients who might otherwise face permanent colostomy. Welcome to this episode of Spilling the RT. I'm your host, Emily Bassett. Surgery to treat distal rectal cancer often results in the removal of the entire rectum with the sphincter and placement of a colostomy that is most likely permanent and obviously a major quality of life detractor. So how are you at the University Hospital Tübingen using Elekta Unity MR-Linac to try and change that?
Thank you first of all for the invitation to this podcast, and it's really a pleasure to be here with you today, virtually. And so to answer this question, let me go back a couple of years. Now, the treatment of rectal cancer is so-called multimodality treatment, which means that many disciplines are involved. This includes surgery, this includes radiotherapy and chemotherapy. And the combination of all these treatments has led to really huge improvements in treatment outcomes in terms of survival and recurrence rates. However, unfortunately, and this is not only surgery, it's the combination of all treatments has led also to severe quality of life impairments, not only for patients who need a colostomy, but also for patients who who don't have their sphincter removed, but for instance need a very distal anastomosis. These patients suffer of so-called LARS syndrome, and that is, even though the R stands for resection, is also caused by radiotherapy and the combination of all treatments. So in the last years, the community was wondering, how can we keep this excellent oncological outcome data in terms of recurrence and survival, but maybe improve quality of life? And so the question was, where can we de-escalate? And for instance, we now know that in certain situations, you don't need radiotherapy. For a proximal rectal tumor that is far away from the sphincter, many of them can go straight to surgery and don't need radiotherapy and benefit from superior quality of life. However, at the other end, in distal rectal cancer, when the tumor is very close to the sphincter, we now know that not all patients need surgery. So if after radiotherapy or chemoradiotherapy, you don't see a tumor anymore, you can leave out surgery and the patient can undergo a surveillance program with MRIs and rectoscopies and benefits massively in terms of quality of life. So the question that came up, of course, was how can more than 10-15% of the patients benefit from this? And many treatment protocols have been developed and tested in clinical trials with the goal to improve complete response rates to radiotherapy or chemoradiotherapy. And one of them is dose-escalated radiotherapy, which means that you're giving a higher dose of radiation to the tumor with the goal to have it disappear after you're done with treatment. And what we're doing in Tübingen is, in our organ preservation program, to use the MR-Linac to give these high doses in a very precise and adaptive way and achieve higher complete response rates than we were used to in patients with distal rectal cancer.
So this is a boost to the sort of standard way of doing the radiotherapy at the moment?
So this is, the boosts are coming on top of the standard way of radiotherapy, yes. So we actually have many patients who are treated at remote centers for their standard radiotherapy, and they come to our center once a week to get a boost dose, a 6 fraction per week to the primary tumor, and this works quite well.
And which individuals sort of qualify for the Tübingen protocol for this?
So this is particularly interesting and relevant for patients with what I call early but terribly located tumors. So these are tumors with an early T stage, so T2, T3, only very limited nodal involvement and non-circumferential growth, but very close to the sphincter. Because these are tumors that have a rather low risk for distant metastases because they're rather early tumors and could theoretically or practically be cured with surgery alone in many cases, however, at the price of permanent colostomy. So our argument for the dose-escalated radiotherapy protocol, in contrast to escalating on the chemotherapy component, is that these patients mainly have a local problem that can be tackled with locally intensified treatment with a higher than usual radiotherapy dose.
And the kind of ability to get this high boost dose in, do you think it's feasible with any other system other than Unity?
Well, when we started to work with the Unity a couple of years ago, actually one of the first things that came to my mind as a use case, as a good indication, was rectal cancer, because we knew about a dose response in rectal tumors, but we also knew that you have to go rather high on the dose, so a little bit escalation doesn't make a difference. And with a cone beam-based CT system, it's very hard to give these high doses because you simply cannot see these tumors on a normal cone beam CT. Plus, they move a lot. So depending on the filling of the rectum or the bladder, you can have more than a centimeter of anatomical uncertainty. So the tumor is pretty much randomly moving from day to day. Plus, it's shrinking. So you may be irradiating a volume that is double as large as it has to be because you're not detecting a tumor shrinkage. And with the MR-Linac, we are able to see these tumors. We are able to see where they're exactly located while the patient is on the table and whether it has become smaller from week to week. And we can therefore adapt the size of the boost volume, and also, of course, we can make sure that we're actually hitting the tumor accurately.
I remember when I was an RT and we first started using CT for lung tumours and actually seeing some of those tumours kind of disappearing. So I think it must be really satisfying to be there on the machine as a therapist and see something with MR that you couldn't see before also shrinking.
Absolutely.
Yeah, and I think, so the sixth fraction, is that always delivered if you're seeing this shrinkage?
Actually, the very first patient that we treated now, when was that? 4 years ago, more than 4 years ago. There we actually stopped after 3 of 5 treatments that we had planned because we were simply not able to see the tumor anymore. And so we stopped. To answer the question, yes, we stop once we are not able to detect a residual tumor anymore, or if we, after 2 fractions, already see that like the tumor has shrinking by 95%. This also reflects the biology of the tumor, so it's very likely that you don't need any further treatment, and which of course then again reduces side effects. So yeah, we often stop at after 3-4 fractions. We have the impression that we don't need it anymore.
I think that's great that you've got the confidence to do that, because I think people talk about response-guided RT as something in the future, but actually that is response-guided RT because you're seeing that
Definitely.
response and you're adjusting your fractions based on it. So, so if you could just summarise the findings so far, but also maybe say like how it impacts your understanding of therapeutic strategies for rectal patients.
So our experience so far. I shared some of the data last year at the MR-Linac consortium meeting in Singapore, and back then I reported on the first 20 patients that we treated, and we had and I will explain that in a minute, a 2-year TME-free survival rate of 94%, which means that after 2 years, 94% of the patients did not need major rectal surgery and were alive. So this is a standard endpoint that is now used in clinical trials. And as I just said before, we were used to 10-15% in locally advanced rectal tumors of complete response rates. And with dose-escalated radiotherapy, we were obviously able to increase this figure by quite a bit. But to be fair, of course, these are earlier tumors than the tumors that we used to treat in the past. But still, I mean, anything beyond 80% is wow. I mean, this is something that we were definitely not used to in the past.
And obviously, this is your area of specialism. But can you see this potentially impacting other patient groups as well?
Well, whenever you have a tumor that is hard to see on a cone beam based system, and you can now see it on the MR-Linac, of course you wonder, can I treat this tumor differently now than I was able so far? And if we think of pancreatic cancer, for instance, these are also tumors that we used to treat in the past, but mostly over 5 weeks with concomitant chemotherapy and with a dose that was definitely not sufficient to be ablative. And similar story as in rectal cancer, we can now see the tumor, we can see it day to day, we can, well, these are not shrinking too much, but if they do, we can adjust and adapt. And yeah, so pancreatic cancer SBRT is definitely also a field that has dramatically changed after the introduction of MR-guided radiotherapy. Yeah. In general, the upper abdomen, everything, liver, lymph nodes.
How are patients responding?
So the MAS trial will start recruitment hopefully this year, but the patients that we treated so far, as they will be treated in the MAS trial, I mean, they love it because it's easy to understand for them. I think that's important also in a clinical trial if you want to convince patients to participate, that it's intuitive and easy to understand. And what are really nice moments is when you can actually show the patients the images. So some of them were asking whether they can see the scans and would just come out of the Linac, of the bunker after the beam is off and would straight come to the monitor, and I can tell them, hey, look, your tumor is only half the size and it's just week 2. These are really beautiful moments. And yeah, so yes, I mean, our patients, of course, link big hopes to this treatment, and yeah, and get immediate feedback from week to week about the situation.
The MARS trial, MR Adaptive Dose-Escalated Radiotherapy in Rectal Cancer. Clinicians at Germany's University Hospital Tübingen are working to change the way rectal cancer is treated by employing their Elekta Unity MR-Linac to deliver a high-dose boost to rectal tumours. The MARS trial is a clinical study that will recruit this year, aiming to improve quality of life for patients with distal rectal cancer by avoiding surgery, especially the kind that results in a permanent colostomy, without lowering the chance of cure. Traditional treatment often involves surgery after chemoradiation, which can lead to permanent changes like a stoma. MARS trial treatment aims to boost radiation dose to the tumour while sparing healthy tissue, increase the chance of complete tumour response, meaning the cancer disappears, and avoid surgery if the tumour responds well, allowing patients to enter a surveillance programme instead. Qualifying criteria includes patients with small rectal tumours, less than 4 centimetres, in the mid to distal rectum with no distant spread. Patients receive chemoradiation over several weeks. A high-dose boost is delivered to the tumour, often once a week, using MR-guided radiotherapy. MR imaging is used to track the tumour's size and position. If the tumour shrinks, the radiation plan is adapted in real time. If the tumour disappears, patients may skip surgery and be monitored with regular scans. In early results for patients treated with the MARS protocol, most patients avoided surgery and had a complete response. Side effects were minimal and quality of life scores remained high. The trial is now expanding to more centres worldwide and will recruit patients from sites including Wisconsin, New York, Toronto, Manchester, Utrecht, Tübingen, and Melbourne. The MARS trial was part of the hypothesis testing program, or a sort of winner, if you like, of that, which is obviously a great way to support evidence generation. And how would you kind of describe why it was prioritized in terms of, is it the highest patient potential impact that wins you the support?
Well, I mean, we had. I mean, I've seen the presentations of the other groups, and I have to say they were really all amazing, and really great people behind these proposals.
Oh,
And
award winners always say that about the other contenders, though.
I know, but this time it's true. Well, I mean. And I'm also sure that we will see the other protocols also getting into clinical trials, maybe in the HTP or outside. But I think it's one criterion might have been that colorectal cancer is, of course, a very common disease. It's a disease that is also very present in media, and it also the MAS trial also it particularly benefits patients who have early detected tumors. So it also to some extent reinforces screening and early detection, and I think these might have been aspects that might have been factors. Plus, if you think of the MR-Linac, if you think of tumor sites where it's important to be able to see the tumor at every fraction precisely and also monitor them, for instance, with what we have now, comprehension motion management. Of course, rectal cancer is comes to your mind quite early. And I don't know about the I was not part of the decision committees, so I can just speculate. But I'm very happy that Mars was selected for the HTP, and yeah.
I think there's such a tangible impact that I feel like even people outside of the radiotherapy can get straight away if you sort of tell them the concept, because I think everyone knows what a colostomy is and the sort of impact that has on people. So yeah, I think even sort of stepping outside a bit, it's a good thing for radiotherapy in general to hear about these kind of research projects.
It's intuitive, definitely.
Yeah.
It's intuitive. Yeah.
Yeah, and because it sort of came through the HTP and the consortium at large, that means that there's other participating centres, is that right, that are helping to generate the evidence?
Correct. I think, I mean, of course, we treated many patients now with the MAS protocol. I was just looking into the data these days. We've hit 40 now, and so 40. But of course, whenever you have the opportunity to run a protocol multicentrically with other centers, you should do that, because maybe patients in other centers are different, have different tumor stages, or you encounter other challenges in terms of workflow, etc. So it's not only a great opportunity to generate evidence, but also to roll out this protocol to other centers, and also allow other patients to participate outside of our tiny little Tübingen.
So they would also be, as a group, are determining things like the optimal dose, things that you can kind of put your heads together on.
Correct. I mean, it's the MR-Linac consortium and the tumor site group, so the group where we all meet who are interested in rectal cancer. It's a fantastic platform to exchange, share experience, but also develop protocols, and the input you get from discussions from outside your own department or you're outside your own zone is very valuable, because they may point you to things that you missed simply because you never thought of them. So yeah, fantastic platform, definitely.
Yeah. And do you think you ever imagined maybe at the beginning of your career that you would be using MR-guided radiotherapy to do something like this?
So when I started in 2010, I was not even aware of MR-Linac. So to answer the question, no, definitely not. But once we heard about it, of course, I was immediately flashed by the idea that we could use this machine for not only rectal tumors, but also many gastrointestinal tumor sites, which has always been my focus. So, I mean, in rectal cancer, we thought that okay, that's it. We have the big story of total neoadjuvant therapy, which is not so much related with radiotherapy, but was a big paradigm shift in the treatment of rectal cancer. So we had this as a new standard. Then we had dose-escalated radiotherapy, maybe with brachytherapy or with the MR-Linac. So to be honest, a couple of months ago, I was wondering, okay, what's the next big thing? And now suddenly we have trials that are testing radiotherapy with immunotherapy in rectal cancer. So there are more and more studies published in high-impact journals that show that if you combine radiotherapy with immunotherapy in rectal cancer, it leads to higher than usual response rates, which is surprising because in rectal cancer, only a very small subgroup of tumors does normally show response to immunotherapy, these so-called microsatellite unstable tumors. But and they are only 2% of rectal tumors. But for the other 98%, immunotherapy usually doesn't show any response. But if you combine it with radiotherapy, apparently something is happening, and these tumors suddenly reply to immunotherapy. So if I had to bet, I mean, I don't bet, but I think this is the next big thing that is coming in rectal cancer treatment.
That's great. That was my next question. So,
sorry.
No, right. I was going to ask you about targeted therapies as well, but you know, I think I just come back from Astro, and you weren't there.
I wasn't there, unfortunately, no.
But yeah, I sort of try and track the trends of the topics, and immunotherapy continues just to increase. And like you say, even without a huge amount of evidence for a certain indication, there's a lot of people getting behind it, and just the idea that you've already got an immune response generated from radiotherapy. So yeah, I think it's exciting. There's almost too many options to explore. Yeah, I think I agree with you that might be the next kind of thing coming. Maybe we'll see for rectal patients. I'm going to ask you a bit about you now. That's okay. So, what would you say motivates you in your work, in your research?
Well, I mean, I have the privilege of working in a department where if you have any fancy ideas, you can really go after them and then make them true. And we have an environment here that is very inspiring, not only the radiotherapy department, but also the colleagues from the other departments, surgery, gastroenterology, radiology, pathology, endoscopy. And this is something that you find rarely in that really well-working, collegial, fantastic combination. And this is a great motivation to come here every morning and know that you will be working with fantastic people around you in your department and in the other departments, and be able to develop new treatments, to test new treatments in clinical trials, and at the end of the day, for the benefit of the patients, because that's also the beauty of organ preservation approaches in rectal cancer. You see quite early whether you were successful or not, and if you're successful, which is getting more and more often, it is a very positive experience for both the patient and the caregiver, of course, and it's a big motivation to continue there.
I actually spent 2 weeks in Tübingen when we were doing final clinical validation of Unity, so I can attest. I mean, we're going back a few years, but the vibe then sounds very similar to what you've just described. Like very friendly, open environment. Like, and you've felt, that's why when you said, oh, it's small, I was thinking that's not how I remember it. It's certainly a place of big ideas, and yeah, I really enjoyed being there for a couple of weeks.
Well, the entire city is pretty much just a university,
yeah,
University Hospital. It's less than 100,000 inhabitants, so I think it's the smallest city in the MR-Linac consortium. But it has all these really great people and minds in the hospital, and as you said, a very friendly and inspiring environment.
Yeah, and I actually think it's really nice when sort of that kind of work is coming out of a smaller city as well. So yeah, kudos to you all there. So how do you recharge your battery so that you can keep that motivation up?
Well, of course, family. I have 2 kids and a wonderful wife, and
Yeah.
I love spending time with them. Going to football matches at our local team in Stuttgart. Played Champions League last year. Unfortunately, this year not again. But of course, this is a big source where you can go to recharge. And a few weeks ago, I signed up for my first semi-marathon which is taking place in 2 months. It's the first one I'm running 17 years after the last one I did. So. Yeah, big motivation, but also a big challenge, but also a way to recharge for me, just to go out, do some sports in the forest, to run, and yeah.
I do
That's what I
remember. I
like to
remember
do.
the forest actually, like it sort of wraps around the
Yeah.
hospital and the.
Yeah.
So you did your first marathon 17 years ago.
So it was a semi-marathon, so just 21
Still marathon.
kilometers. It's still marathon. Yeah, it still has marathon in it. But yeah, that was 17 years ago, and I just had a big gap, and but suddenly a few weeks ago, I felt the motivation again to start again, and there's a very traditional semi-marathon here in Tübingen, actually on December 6th, what we call Santa Claus Day here in Nikolaus Day, and yeah, there's always a 21-kilometer run on that day, and this is the first time I'm actually running this particular one. Yeah.
Does everyone get dressed up for it?
People do that actually. Yeah, I'm not going to do it, but
Oh, come on.
you see people running their 21 kilometers in a Santa Claus dress. Yeah.
It always amazes me when you see like the London Marathon, this sort of costume. Like, I imagine it's hard enough to run in the first place, and then they have this incredible. You think it must be just so warm.
I'm sure they're throwing it away somewhere during the run. Yeah.
What would you say to someone considering a career in radiation medicine?
I would say congratulations, because that person obviously either met someone who told him or her that this is a great specialty, or for whatever reason had contact with radiotherapy, maybe during medical school or during an elective or during a research project, because unfortunately it's a discipline that is, at least in Germany, not that much present in medical schools particularly. I mean, I ended up in radiotherapy pretty much by coincidence as well. I was assigned to an elective that I never signed up for, but otherwise I would have never thought of becoming a radiation oncologist, simply because during medical school I might have had maybe 3 or 4 lectures on radiotherapy. I'm not sure if I even attended them, I can't remember. Yeah, it's really a fantastic discipline that combines technology with oncology, with really close patient care. And if someone tells me he or she is interested in radiotherapy, I really encourage them to continue this project and start a residency there, definitely.
Well, it's great that fate brought you to radiation oncology. I think the field will be forever grateful. Okay, thank you so much, Cihan, for your time today. It's been great to learn a bit more about the sort of upcoming MARS trial, and I'm really looking forward to following the progress of that work.
Pleasure was all mine. Thank you.
If you enjoyed today's episode, then don't forget to like and subscribe wherever it is on your screen, and tune in for the next episode.